All right, so starting at the top of this, tissue integrity, um, episiotomy purpose, so remember that's just cutting the vaginal outlet to make it bigger for baby to fit. Um, Nothing exciting about that. Rita, just your normal assessments, that's nothing new. Looking at, redness, edema, ecchymosis, discharge approximation, so how you would assess any wound, whether it's a episiotomy, laceration, C-section, incision, anything like that. What are you looking for? What would be normal? Think about if you're assessing a episiotomy, think of the area, it's probably going to be a little bit swollen, a little bit red, that type of thing. Depending on how traumatic the delivery, there may be a little bit of bruising, okay? But is it changing? Is it getting worse? How bad is it? Are we developing hematomas? Those type of things. Infection, mastitis, prevention. So remember, that's a milk duct infection. So how do we prevent that? So making sure the mom is emptying her breast regularly. So we don't want to be supplementing with formula in between, because those are times the breast is staying full. So emptying the breast, good hand hygiene, keeping the area clean. Those type of things are going to be important. Sorry, it says pre-art. It's supposed to be PTL, preterm labor risks. I apologize for that typo. So remember, so this is under infection topic, okay? So what is one of the key things that is a risk factor for preterm labor? It's going to be infections. So a lot of different infections. One of the most common ones is bladder infections. So if you have a mom who's at high risk for that, she's going to be at high risk for preterm labor. Previous preterm labor, preterm deliveries are at high risk. Any genital tract infection, okay? African Americans are at higher risk. Low pre-pregnancy weight patients, smoking, domestic violence, those type of things put people at higher risk for preterm labor. All right, moving along. Just making sure I have all my little notes for you guys. Cellular regulation. So that one, GDM teaching. So what, oh wait, sorry, I skipped perfusion, I apologize. All right, perfusion, postpartum hemorrhage risks. So think of those patients who are at higher risk for postpartum hemorrhage. So anything that's going to overextend that uterus. So large babies, multiple pregnancies. So the more times that uterus has been stretched, it has a harder time shrinking back down. Remember, the goal, the best way to prevent postpartum hemorrhage is for that uterus to contract, be nice and contracted afterwards. We want that involution process to happen, and we want that uterus to be contracted. So anything that's going to prevent that or make it harder. So when it's been used a lot, okay, lots of babies. So if mom's had, 3, 4, 5 babies, it's going to have to work harder. If mom was on medications like magnesium sulfate, remember that relaxes the uterus. Those patients are at higher risk. Worsening preeclampsia signs and symptoms. So looking at those questions that you're asking, part of your assessments when it comes to this. So does mom have a headache? Is it worsening? Is it not getting better with Tylenol or anything like that? Blurred vision changes, upper gastric pain where your liver is. So when that liver gets inflamed, those type of things we're looking at. Think about if your patient was on magnesium sulfate, and that's part of one of the medication talks about that question, but just since we're talking about preeclampsia, I'll bring it up. Remember those assessments for your magnesium sulfate patients. If we started to see them to have diminished reflexes, maybe they're getting too much magnesium, it's relaxing them too much, okay? Or if their reflexes are hyper-reflexive. So when I'm tapping on their deep tendon or that deep tendon and they're kicking me in the face, it's highly reflexive, means that patient could be close to seizing, okay? So that could be worsening preeclampsia because we're not controlling it, we're not trying to prevent that seizure. All right, abruptio placentae signs and symptoms. And and it talks about previa versus abruption. So these are kind of all encompassing. So remember that sheet that I kind of gave you that looked at the variations, the differences between an abruption and a previa. So an abruption is going to have pain. The abdomen is going to feel kind of board-like, hard. Okay. Where a previa, it's painless, okay, that type of thing. So look at those comparisons between the two. How would you tell the difference between one or the other? An abruption, patients who use cocaine are at higher risk for an abruption. Motor vehicle accidents, trauma, domestic violence, those type of patients are at higher risk for an abruption. Let's see, so with that, I think that's it. All right, cellular regulation. GDM teaching, so gestational diabetes, remember that's diabetes within the gestation, within the pregnancy. So teaching, good diet management, nutrition, exercise, blood glucose monitoring, those type of things, the importance of attending their prenatal visits and that type of thing, okay. Insulin needs. So remember through the pregnancy, in the beginning of the pregnancy, first trimester, so those first few months, their insulin needs are lower. That second and then that late third trimester, remember their insulin needs increase, okay? Because remember, insulin resistance increases as pregnancy progresses, okay? So the further along in the pregnancy, the more insulin, okay? Because remember, the baby or mom is trying to give that baby more glucose, more sugar, so it's raising that and it's keeping the insulin resistance increased, okay? Because it doesn't want to subside those blood sugar levels. It wants to give that sugar to the baby, okay? So insulin needs increase, and then postpartum, they significantly drop. So those insulin needs decrease significantly postpartum. And these are all underlined. So all this talking about insulin is part of the short answer questions, okay? Insulin requirements. So same thing, we kind of talked about that based on the trimester of pregnancy and how that progresses. So those two kind of go together. Tight glycemic control. So what does that mean? Just means how are we going to tight glycemic control is keeping control of mom's blood sugars, keeping it on an even keel. So we never want blood sugars to be up and down, up and down. Those can cause vascular damage and cause complications and risks for mom and baby. So we want to decrease those risk factors. That's our goal of tight glycemic control. So just keeping a close eye on those blood sugars and keeping them well controlled. And preconceptual counseling. So making sure, if a patient is at higher risk for having gestational diabetes, we definitely want them to get some preconceptual counseling to get those blood sugars under control prior to getting pregnant, okay? Because think about when a patient gets pregnant, they usually don't go to their first prenatal visit for the first, 5-6 weeks sometimes. Sometimes they don't even know they're pregnant the first month or two. So it just depends. And by that time, if your blood sugars have been so out of control, so many things are forming in that newborn at that time. If we have out of control blood sugars from the beginning, it can cause anomalies in the baby and complications and problems. So we want to have those blood sugars under control prior to getting pregnant.
So that's for a patient that already has diabetes?
That is for anybody. So yes, if they have existing diabetes, but also if they are at higher risk for having gestational diabetes. Okay, so anybody, remember we screen all pregnant women, but we definitely want to look at anybody who has those risk factors for it. So like your overweight, your obese patients, patients that are older than 25, so remember there's a list of some risk factors, so those women definitely want to get preconceptual counseling. Family history of diabetes, previous birth experience with a large baby, those ethnicities that are at higher risk, your Native Americans, African Americans, Asians, Hispanics, those type of things, definitely.
Got it, thank you.
Yeah, absolutely, no, good question. Okay, I think that's it with that. Dosage calculations, I know you guys get a lot of practice with that in med surge. If anybody struggles with that, let me know. We can either talk after or send me an email and if you need some practice questions or anything, okay? And then the medications, I'm not going to go one or through every one of those. Just make sure you look up those medications, know why we're giving those, what they are for, okay? What are some contraindications? What are your reasons for giving that? What type of patient would receive it? Things you would normally want to know about a medication, okay? I'll give you one example, like terbutaline. So we may give that to relax the uterus if a patient is hyperstimulating, so having too many contractions, one right after another. Contraindication would be as if a mom had already a very elevated heart rate, because terbutaline can raise mom's heart rate, which is also going to raise baby's heart rate, makes mom feel like she's having palpitations, that type of thing, okay? So we want to be aware of that and monitor that, and then educate the mom on those things. Keep in mind, so like terbutaline has other uses, okay, but what do we use it specifically for? OB related, okay, and I just told you. But it also has some respiratory uses also. All right, and then special considerations, hypotonic uterine dysfunction. So remember, these are just functional uterine patterns where it's not effective to make labor progress. Okay, it's not going to be effective. Sometimes women will, with this pattern, they'll be progressing along, and then all of a sudden it stops. The contractions become less strong, when normally before they were, she was progressing along, having good contractions and progression. A lot of times it stops and slows down around 4 centimeters. So just look at those hypotonic uterine dysfunction patterns. Bishop score. So remember, this is that scoring system that we look at. How inducible is this patient? Okay, so if we're bringing a patient in for an induction of labor, we want them to deliver. We want to induce their labor. How effective is this induction going to be based on how dilated their cervix is, the position of the cervix, the location of it, those type of things. Okay, so it's out of 10 points. So look at that scoring system and what it calculates, and what would be ideal if we had a low Bishop score. So if a patient had a low Bishop score, a 2 or a 3 or something like that, we're probably not going to jump right to some Pitocin and start forcing contractions against a cervix that's really hard and probably closed up. Because if you have a low Bishop score, that cervix is probably not soft, it's probably not dilated much at all. So pushing contractions against in a hard cervix is not going to do much. So we want to do some cervical ripening. Okay, so remember those medications, maybe some Cytotec or Cervidil, to soften that cervix first, and then we can move to Pitocin. Okay, so what types of things are we doing based on that Bishop score? Think about that. Prolapse cord interventions. So remember, a priority if amniotic, if the membranes rupture, so that amniotic fluid spontaneous ruptures or we artificially rupture it, what is our focus? Fetal heart tones, okay, because we're concerned that you could have a prolapse cord. So if you're seeing fluid leaking from your patient, if we rupture, so she may have had, or she's complaining of increased fluid leaking, she may have spontaneously ruptured. If we go in and rupture her, we want to watch for that. So heart tones usually will decrease, and then we'll do a sterile vaginal exam and we'll feel for any prolapsed umbilical cord. And what would you do if you did that, heart tones went down, you went in vaginally and found you could feel that umbilical cord? What are we going to do? Our goal is to lift that presenting part up off of the umbilical cord, because that umbilical cord is the lifeline for the baby, right? So we want to lift that presenting part up off of there, and then we're going to, which would be your priority, and then we're going to get her delivered. Okay. What else? Shoulder dystocia. So remember, that's when that anterior shoulder gets caught under the mom's pubic bone where it can't deliver. So what do we need to do for that? We need to enlarge that pelvic outlet. So we need to enlarge that outlet your first thing you're going to do is McRoberts position. Remember, putting mom's legs back up as far as possible, which increases that diameter of the pelvis. So McRoberts position, if that's not working, suprapubic pressure, we're going to continue to do that. And then we're going to do suprapubic pressure where we're pushing down against that anterior shoulder to try and get it to fold under that pubic bone. Okay. Okay, that's it with that. What else? Women's health. Let's see. Breast self-exam guidelines. So remember, the American Cancer Society came out with a guideline not too long ago, a few years ago, that said it's optional. Okay, so keep that in mind if we're going to teach them to do that. Ideally, 5 to 7 days after their menstrual cycle is ideal time, just due to the changes in the breast with the hormones during their menstrual cycle. But just keep in mind it's an optional thing. They still should have their healthcare provider do a breast exam at their annual physicals. However, they don't need to do them monthly anymore. Okay, that's optional. Osteoporosis, risk factors. So remember who's at more risk for that. Your small body framed people. The older you get, the more risk you are. Okay, so there's a list of risk factors on that. Caucasians, Asians are at higher risk. Patients who drink more alcohol, smoke, those are definitely at higher risk. What else? Family history of osteoporosis. Anything that's going to decrease that estrogen. When that those estrogen levels decrease, osteoporosis risk increase. Okay, so early onset menopause. Okay, remember now, with that, I don't know where it's going. Early onset menopause, which just decreases that estrogen. Let's see, I think that's it. All right, lost my spot. That's it on that. So risk factors. Okay. On the SSS, choosing appropriate birth control methods. So think about those questions. These are underlined. So it's part of your short answer. So thinking about those questions to ask those patients on what is their goal. So do we have long-term, short-term goals for birth control? Does the patient have problem touching her body? Is she going to be able to insert something or not? Is she going to be able to take pills regularly? Does she have multiple sexual partners? So do we need a barrier method, or do we need, or is she monogamous with one partner? So maybe you don't need that because you're not trying to prevent STIs also, most likely. Maybe we're just trying to prevent pregnancy. So looking at all those types of questions that we want to ask your patients when choosing that. Looking at, are they a smoker? Do they have high risk for DVTs? Those patients, we want to not utilize birth control methods with increased estrogen levels in them. Okay, so like your COCs, your combined oral contraceptives, they have both the progestin and the estrogen in them. So those patients who are at higher risk for blood clots, if they're a smoker, things like that, we high blood pressure, we don't want to give them estrogen because that's going to increase that. Okay, those risk factors. Keep losing my spot. What else? All right. Perinatal loss. Okay, so what we do if we had a loss, if a baby dies, what are those, think about the grieving process, think about how we can include the family. With COVID, unfortunately, it's a little bit different, but typically we would want to involve the whole family, let all the family come in and see the deceased baby, including siblings, grandparents, that type of thing. Let them name the baby, give them some mementos. So anything the baby was dressed in, if they had any hair, depending on how far along they were. So get a lock of hair, pictures, those type of things. So which can help with that grieving process. Spiritual support. So remember that a patient's spirituality changes as their life changes. So as they get older, spirituality changes. Think about who you can collaborate within the hospital when we're talking about spirituality care of a patient. So remember, you always have like pastoral care within the hospital setting that can help with that sometimes. LGBTQ issues. So in relation to these topics, what are they, more issues might they have more of? So a lot of times they don't seek healthcare because they're fearful of prejudice or, not impartial care, those type of things. They may have fertility issues that need to get addressed, okay, when you have same-sex partners or things like that. So what type of fertility issues can we help them with? What else? Partner rights, okay, insurance sometimes is an issue because maybe they're not on their significant others' health insurance policies and things like that. Birth control options, kind of talked about that a little bit with choosing those appropriate birth control. But think about those different options when we talk about your barrier methods, your hormonal methods, your all those types of things, and thinking about which method is going to be appropriate for which patient. What else can I think with that? If we are looking at like more behavioral methods, so fertility awareness methods and things like that. So only having sex when they're typically not, when they're not fertile, so when they're not ovulating, those type of things. So just remember you have those different variations. You have that behavioral methods, your barrier methods, your hormonal methods, okay? And then remember there's some emergency contraception methods also, okay? So don't forget about those, which could be the copper IUD, okay, which can be inserted up to 5 days after the encounter, which is about 99% effective. And then you can also purchase some contraceptive pills over the counter. And those need to be taken within like 72 hours. Let's see, what else? And COC contraindications, I kind of included that when we were talking about birth control methods. So those contraindications are going to be those estrogen medications. So those hormonal methods that have estrogen in it, patients with elevated blood pressure, migraines, smokers, DVT risks, they want to avoid those. Okay. All right, that's it with that. Family dynamics and violence. Where'd I go? Okay, sorry. Like I'm doing a puppet show, like up and down. All right. Domestic violence assessment. So what are those key assessments? Always making sure we try to interview that patient by themselves without anybody else in the room to try and get a true story. Not everybody's going to admit to anything even when they're by themselves, but you have a higher chance when they're not in there. What else? So looking at locations on their body of bruises and marks and things like that. Are they coming in with repetitive different stages of healing of bruises and marks and things like that? Your most common areas of abuse in a pregnant woman are typically the face, the breasts, and the abdomen. Okay, so those are some of your most common areas. So looking for that. Phases of violence. So remember there's like that cycle, a little picture, that cycle of violence, which usually occurs in domestic or any type of violence when it comes to domestic or intimate partner violence. So usually there's that tension building phase, okay, where things kind of build up to that tension, and eventually it leads to the next step, which is the abusive phase, okay, which then a lot of times leads to the honeymoon phase, where the abuser is very apologetic. I'm sorry, it'll never happen again. I didn't mean to do that, make excuses for everything, okay. a lot of times the partner forgives them because they're so sweet and caring, and they, you know, want to believe that they've changed. And then again, just tension builds, abuse, honeymoon phase, and it's just a circular, never-ending pattern a lot of times, unfortunately. There are, and I'm going to jump down to, while we're talking about that, the domestic violence myths. Okay. So, you know, a lot of people think that if somebody's being abused, you know, a lot of people, it's easy to say, well, you know, just leave the situation. You know, why would you stay with this person if they're abusing you, if they're hurting you? Again, part of it is that honeymoon phase, okay, where they want to believe that they are going to change. They love the person, okay? And again, they want to believe they're going to change. Sometimes it's due to financial constraints. They have children. Maybe they've been threatened with their life that if you leave me, I'm going to kill you, or I'm going to take the kids, or I'm going to kill the kids, or a lot of that guilt or those things they hold over their head. So it's not as easy as it sounds. You know, if you've never been in that situation, you know, don't judge people if you've never been in that situation. Do what you can to help those people. Some other myths, let's see. A lot of times people think that being pregnant protects the woman. They think that they're not going to be abused during pregnancy. That's totally a myth. Actually, pregnancy or domestic violence increases during pregnancy. Okay, why we need to really be in tune to those assessments and things. It's a very emotional time, so that can increase. You know, it's a myth that it only happens in lower socioeconomic classes and things like that. That's a myth. That's not true. It can happen to anybody, anytime, in any class. Let's see. Another myth: alcohol and drug abuse causes the battering. This is a myth. Okay, so even though sometimes alcohol may be involved in the abusive incidents, it's not the cause. Okay, alcohol does not cause somebody to abuse somebody. Okay, a lot of times they'll use that as an excuse. Okay, but it's not. Okay, and like I said, you know, a myth is that women would leave the relationship if the abuse was really that bad. That's not true. Okay. Like I said, women a lot of times stay in the relationship out of fear of financial dependence, things like that. They don't want to take their kids to shelters, all sorts of things. Okay. All right. So let's hear violence. What else on here? Family systems theory. So with that, what did I say? Family systems theory. So remember, these are those theory models that that one believes that the family is part of a larger super system. Okay, so they believe that that whole system, not just the individual family, the whole super system, anything that's involved with that family, any outside factors, is greater than the sum of its individual parts. Okay, so when you work together with you know, your family, your you know, whatever your resources are, your support people, support places, whether it's cultural, religious, or activities, hobbies, those type of things. Those things individually are not as great as the whole of all of them put together. Okay. Health belief model. Health belief model focuses on decreasing cultural and environmental barriers to access care. That's kind of their goal and function. Okay, so they want to reduce those barriers that interfere with access to healthcare, I should say. Okay, let's see. Family types. So those are just your different types of families, like the nuclear family, your extended family, married blended family, which is a really common one. What else? So who is involved in that unique family? Okay, if you kind of stop and think for a minute, like, what does your immediate family consist of? What would you be titled as? How many other types of families do you know? Okay, do you know people that have, you know, the nuclear family, the married blended family, all these different things? Okay, so think about that. We already talked about, violence myths. So we're good with that. Legal and ethics. Documentation. So remember, documentation is vital. Make sure you have clear and concise documentation of what transpired. Okay, to protect you. Think about specific to labor and delivery. That fetal monitor strip, if you have a paper one in the room, that is part of the legal chart, so do not chart on that. What else? Just good, clear documentation. Be able to understand, what transpired. Social media. So I know I gave you a lecture on this, so I won't go into much more detail, but just the goal is to not violate patient privacy and confidentiality. Okay, so just be mindful of that. Safe practice. This is kind of like when we talked about you have like a critical care nurse who maybe got pulled, or can she be pulled to labor and delivery, such a specialty area that needs highly special training when it comes to like fetal monitoring. Okay, so she needs to be able to speak up and say, hey, I'm not well educated. I don't feel comfortable being pulled to this unit because I don't have enough education or training in fetal monitoring, and that type of thing. So think of those specialty areas. Employee liability, we talked about, say if you go to work on a unit that may do a good number of abortions and you have moral, ethical, religious, whatever beliefs against it, you need to inform your employer at time of employment that, you don't feel comfortable taking care of those type of patients. You can't wait till that patient's coming to the floor and be like, yeah, no, sorry, I'm not doing it. Okay. Antepartum, so your GT-PAL, so just be able to understand what all those stand for. Remember your G, gravida, number of pregnancies, T, any deliveries 37 weeks or beyond, P for preterm, anything before that, before 37 weeks, A for abortions, so any miscarriage, whether they're abortions, whether they're spontaneous, induced, therapeutic, whatever. It's anything below 20 weeks. L is for any currently living children. Okay. EDC, so estimated date of confinement. So looking for that due date. So remember, you look at the woman's last menstrual period, first day of her last menstrual cycle. Subtract 3 months, add 7 days, correct for the year if you need to. Okay, so do some practice questions, be able to calculate that out and figure that. NST components. So that's your non-stress test. So look, what are we looking at? We're putting the mom on the external fetal monitor. We want to see a good baseline, heart tones between 110 and 160. We're looking for 2 accelerations within 20-minute time span. Okay, within 20 minutes, we want to see 2 accelerations in those fetal heart rate, which remember is typically 15 beats above baseline for 15 seconds. Okay, if you don't see that, we want to do a biophysical profile. So think about, what does that tell you about the baby? Amniotic fluid functions. So remember, that's that fluid that's floating around in the uterus, around the baby. Remember, this does not provide nutrition, okay, to the baby. Even though the baby swallows it and pees it out, there's 0 nutritional value. It's not providing nutrition. Mom provides nutrition through the placenta, through the umbilical cord. But it provides a neutral thermal environment, so a nice, perfect bath water temperature. It cushions the baby, cushions the cord, allows that cord to be, float around in there, be very buoyant, and floats to keep that compression from happening, or keeping trauma from happening to it as best as possible. Okay, postpartum, we might get through this. Okay, postpartum fundal checks. So remember what we're assessing. We're feeling the fundus, the top of that uterus, in relation to the umbilicus. Where is it? Okay, and where is that based on how far out they are from delivery? Okay. Upon those assessments, what are we finding? So remember, if you have a boggy fundus, okay, with nothing on it, it's in a perfect spot, it's nice and midline, but we have a boggy, soft fundus, and they may be bleeding. Your priority would be to massage it, okay? However, remember on that last exam, I'd asked some questions about a fundal assessment and having it deviated, okay? So It may be boggy, it may be soft, but the key is it deviated to one side or the other? A lot of times it'll be elevated just because that bladder is full. But anytime you see that it's deviated off to the side, remember that's an indication that the bladder is full, okay? So your priority changes when you have that added to your assessment. Your priority changes to emptying your bladder. So put her on a bedpan, straight catheter, whatever you need to do. We don't want to get her up and send her to the bathroom.
Okay.
Empty that bladder. We have to fix the underlying cause. Is somebody gonna say something?
I'm sorry. Could you repeat that one more time with the difference as far as like the treatment?
Yeah, so if you just had a boggy fundus, a soft fundus, but it was in the perfect location where it should be, nice and midline, your priority would be massage it, okay? Because it's probably just uterine atony, you're gonna massage it. But when you add that element of deviation, so if you have a boggy fundus, but now you've added, it's not midline, it's deviated, it's off to one side or the other, that is an indication that the bladder is full, okay? So your priority changes to emptying that bladder, okay? So remember that in your assessment pieces, your interventions change based on your entire whole assessment. So when you have a deviated fundus, your priority is bladder. Just put them on a bedpan or straight cath them, okay? Because you have,
Sorry, go ahead. Finish what you were saying.
So you have to fix that underlying cause. You're not gonna control anything if you don't fix that underlying cause, which would be the full bladder. Go ahead.
So on the last exam, and I know you addressed this in the last lecture, there were two questions that were very similar. And I don't know my memory right this minute, which I can't count on that, but it seems to me that both of the questions, the bladder was deviated or the fundus was deviated to one side, but the treatment was different. Am I right? I can't really remember what, I was going to ask you about that. So
that's fine. You know, actually the answers were the same. They were worded a little bit differently. But in both of them, I'm trying to remember, both of them
were emptying the bladder. One was on a bedpan and one was,
I think straight cath or something, I think.
I think the only
Yeah, I was
difference
answering
between the
the
two questions is one had it deviating to the right and one had it deviating to the left.
Yeah. And I think
And one said empty the bladder. One answer was empty the bladder on the bedpan, and the second answer was to straight cath the patient.
Yeah, and I think one also had an added element of the assessment that it said the fundus was +2, so it was elevated more. I think one said that one didn't. So either way, regardless of anything else going on, if you have that deviation to either side, okay, your priority is bladder, empty the bladder. Doesn't matter how you do it, empty the bladder, okay? Ideally not getting them up to the bathroom because if they have, we're worried about, remember, we're worried about hemorrhage, okay? So we don't want them to hemorrhage walking into the bathroom and pass out and fall and hit their head, okay? We want to limit risks. So bedpan, straight cath is usually your goals, but emptying the bladder, okay, is gonna be your priority, okay? Anytime you have that deviation, okay? Make sense?
yes, it does. Thank you.
All right, good. All right, physiological changes after delivery. So think about all those changes the body made prior to or in the beginning of pregnancy and throughout pregnancy to prepare for delivery, increase blood volume, all of those things. Now we're talking postpartum. That body's got to go back to normal. So that involution process, that uterus needs to shrink back down to size. You're going to have diuresis, diaphoresis. Okay, so lots of urine output, lots of sweating. Your patient's probably going to complain of sweating. What's going on? It's just the body's way of expelling that fluid, getting rid of that fluid, right? That's normal. Increased white blood cells. Remember, they can be up to 25,000. So just kind of think about that, all those physiological changes that are occurring to get that body back to or as close to normal or pre-pregnancy as they can. All right, intrapartum. Sorry, I'm trying to make sure I have notes for you guys. There we go. Stages of labor. So just be able to identify those. Okay, so no. And this is underlined, okay? So you need to be able to talk to this better, for sure. So remember those different stages of labor based on what's going on. So that first stage is all that cervical dilation, okay? So, but remember it's divided into 3 phases, okay? So first stage, so it's like you're up on a stage, okay? It's one stage, okay? But have that stage divided into 3s, okay? 3 phases of that stage. So that's that dilation. So latent, it's gonna be 0 to 3. Active is gonna be 4 to 7. And then transition is going to be that 8 to 10. Okay. So be able to identify if I said this patient's 5 centimeters dilated, what stage and phase is she in, be able to identify that. And then moving on from the first stage, knowing what's happening, what's going on. So second stage is going to be, starts at 10 centimeters. Okay. And it's that pushing. So mom is pushing. Okay. So once she's 10 centimeters, she moves into that second stage of labor. And she's going to start if she's pushing. Okay. Third stage is going to be your placenta delivery. Okay. So that baby is delivered. Now we have to deliver the placenta. So that's your third stage. Fourth stage is going to be that recovery. Okay. So it begins after delivery of that placenta. Okay. All right, so be able to identify those and what happens within those. Poison. So remember when we have late decelerations, okay, so be able to understand what would a late deceleration look like on a fetal monitor, okay? If you saw a contraction, remember you have to be able to see a contraction to identify a late. If you see the heart tones, I'm not sure why I'm drawing like in the air, but like you can figure out what I'm doing maybe. But if you have a contraction and you have the decel that starts at or after the peak of the contraction, this is a late deceleration. Okay, maybe I'm going backwards, but I don't know if this camera reverts it, but anyway. So look at some pictures of late decelerations, be able to identify what those would look like. They don't have to be extreme. They can be kind of subtle decelerations. It just depends, but look at the timing of it based on a late deceleration. What do I do? Oh crap, I have late decels. Those are bad. Okay, we need to poison our patient. Okay, I mean, not literally, but so remember position change, oxytocin off, IV bolus, sterile vag exam, oxygen, 8 to 10 liters, non-rebreather, notify your provider, okay, and then reevaluate. Okay, we want to reevaluate what's going on. Did it help? Are the lates better? No, maybe we need to reposition her some more. All right, intrauterine resuscitation. So a lot of that is involved in this poison, okay? So if we have bad fetal heart tones, altered fetal heart tones, we have late decelerations or maybe variables, okay? Maybe we want to change the position of the mom to relieve that pressure off the cord of a variable to try and get those heart tones better, resuscitate that baby in utero before jumping to delivery. Okay, we want to make sure that baby is happy, healthy, has a good heart rate inside. The lates, we're going to do the poison. Okay, that's part of intrauterine resuscitation, we call it. Epidural assessment. So if you have a patient getting an epidural, what are your priorities? What are we looking at? So yeah, pain relief. We want the goal of an epidural is for them to get some pain relief. But one of the biggest factors of an epidural is blood pressure change. Okay, so we really want to monitor that blood pressure. Blood pressure can drop, which can decrease your fetal heart tones in turn and cause us to do a crash C-section because of those fetal heart tones. So blood pressure is going to be your key assessment when the patient has an epidural, okay? And then which is your initial changes, and then yeah, ultimately pain control. But priority is going to be blood pressure.
With the blood pressure changing, like, would they like decrease the amount of like medication that they're getting, or?
So not so much. Usually it's the initial insertion and the changes depending on, so what we try and do is to prevent it is try and hydrate the mom. So we give them an IV bolus to keep those vessels from causing those changes, that drop in blood pressure. So a lot of times if they have that drop in blood pressure, we're going to open up those fluids, give them lots of fluids. We may give them some ephedra to raise that blood pressure up prior to lowering that medication, because it's usually that initial medication that test dose kind of they give to into the epidural, which causes this. So it's not so much just by decreasing the amount that's going in, we need to fix it first. We need to fix that blood pressure. So we're going to give them fluids, give them medications to increase that blood pressure. If that's not helping, we could ultimately turn the medication down, but typically that's not what's causing it. The currently running epidural is not what's causing it. It's usually that initial medication that they're pushing through that.
That makes sense.
Okay. All right. Newborn, so assessments of newborn. So think back of all those assessments, sorry. Let's see. So your cardiovascular or your your vital signs. So know what those normal rates are. Your respirations 30 to 60, your heart rates 110 to 160, normal temperatures, what assessment pieces. So looking at some of those reflexes, sucking, rooting reflex, looking at checking for hip dislocation. Remember that Barlow Ortolani, where we're rotating those hips and feeling is that does that hip move out of socket. I can't think of the word for hip bone. But anyway, so looking for that. So what is that called? What are we identifying when you look for hip dislocation? Also, you can look at knee height. So the wrinkles or the creases within the knees, are they equal or is one higher or lower than the other? What else? Skin changes. I would look at some of those skin assessments. So what's a normal newborn rash? That erythema toxicum, what does that look like? Be able to identify that. That's not contagious. It's transient. It'll come and go. What are some other things like your stork bites? So those nevi, like kind of mole looking things, stork bites. So look at some of those skin changes also. What else? I think that's it. Circumcision. So what is your care? So when we're removing the foreskin of the tip of the penis, which is an optional procedure, but how do we, yes, that's care. How do we care for those afterwards? So we want some Vaseline on a gauze, put it on the tip of the penis, then put the diaper on top, and that just helps keep things from sticking, or the diaper or anything from sticking to the raw site. Okay, watching, monitoring for signs of infection, those type of bleeding, those type of things afterwards. Educating the parents on that care and changing that gauze every time you change the diaper, things like that. Keeping the area clean, good hygiene, making sure babies pee afterwards. We want to make sure nothing was affected by that. NAS, so neonatal abstinence syndrome assessment. So how would we know that's what this baby is going through? So typically those babies have like that high pitched cry. Remember, a normal baby should have a lusty, low tone pitched cry, where babies, when there's something wrong, especially NAS, things like that, have that very high, shrill type of cry, high pitch. We don't like that, something's wrong. They're irritable, typically inconsolable a lot of times. They're usually poor feeders, but always looking like they're hungry, mouthing, looking for food, but they don't feed very well. Maybe tremors, things like that. What would we do? So if we suspect NAS syndrome, we want to get a meconium sample. So get some of the stool meconium, one of those initial poops. Ideally, the very first poop would be ideal, and send it to the lab to check for any drug abuse within the baby, or not drug abuse in the baby, but drug abuse from the mom that has transitioned to the baby. Okay. Oxygenation, newborn breathing patterns. So remember, newborns have a unique breathing pattern. They are irregular, shallow, they should be unlabored. Okay, we don't want to see retractions, use of those accessory muscles, flaring, grunting. We don't want to see that. But irregular, shallow, that is normal. That is okay as long as they're unlabored. Those type of things. 30 to 60 is your normal rate. What else? Extrauterine transition. So what are your key systems that go through transition in a newborn? So remember, respiratory and cardiovascular, those are the main changes. Okay, so respirations, we want them to take that first breath, expel that fluid from their lungs. Cardiovascular, needs to make a change. So respiratory and cardiovascular systems, dry, stimulate those babies. Okay. All right, characteristics of heat loss. So remember what's unique to newborns. Why are they at such high risks for heat loss? Remember, they do not shiver. They do not have that shiver mechanism that we do. They have very little subcutaneous white fat, so which would keep them warm. So that's why they're at higher risk. They have a larger body surface area to body mass. Okay, so they have more external surface compared to their entire mass. So more exposure available. What else? I think that's it with that. Methods or modes and examples of heat loss. And again, this is underlined. So part of your short answer questions. Remember when we talked about those 4 different modes of heat loss, conduction, convection, radiation, evaporation. So be able to talk to those. So if you had a patient who was losing heat through, say, conduction. Okay, so remember that's going to be transfer of body heat to a cooler, like an object. Okay, so say your stethoscope touching the baby. So how do we prevent that? Okay, we want to warm that stethoscope, warm our hands before we touch the baby, put them on a warm bed. So it's direct contact, those type of things. So same thing, convection. So it's losing heat through that flow of heat from the air surrounding the baby. So if we have cold air around that baby, they're going to lose heat more. So how do we prevent that? So good room temperature, warm room, eliminating drafts. So close windows if there's a draft, things like that. Air conditioners, keep them away from those. What else? Those type of things. All right, so just kind of look at all of those. What else? Evaporation. So remember, why we dry that baby when they're first born, so we get all that amniotic fluid, that wetness off of them. And then your radiation. Okay, cooler object within the room. So if you have like a cold window, so if it's cold outside, the window is going to be cold because it's touching that cold. So radiation, if that baby is close to that window, that coldness can radiate from that cold object. They're not contacting anything, okay? But so we want to move babies away from those exterior windows and things like that. Okay, so just be able to talk to those. Okay, I think we got through that. Oh, only 2 minutes over. I'm impressed. All right, so that is that. Any